This is why I will choose a Medigap or a Medicare supplemental policy when I'm 65 as opposed to Medicare Advantage. I'm going to read you an article, part and parcel of why the Medigap is, in my opinion, better than Part C. I have no idea what your current situation is, your cash flow, I don't know. But I'm telling you, man, as it comes time to choose Medicare supplemental policies or Medicare Advantage, again, those are called Part C, you got to know what's going on with the Medicare Advantage plans. And I'm a huge fan of vouchers. I'm a huge fan of the free market way that the voucher programs through the Medicare Advantage programs work. It's a tough row to hoe on a regular basis if you're ever going to need to exercise your rights under Medicare Advantage. And I'll share with you why. All right, so let's go into this from the New York Times today. And look, I don't trust the New York Times as far as I can kick them. I mean, the New York Times is the swamp, part and parcel. But they do have some good articles on occasion. I don't subscribe or anything like that. But this is one that I think you should be well versed in for sure. Dateline is July 8th, 2019 by Austin Fracht. Even researchers don't know which doctors Medicare Advantage covers. A study found that Google was more accurate than the program's physician directories. If you try to use Medicare Advantage, figuring out which doctors are available and where can be exceedingly difficult, if not impossible. Medicare Advantage is a government-subsidized private alternative to the traditional public Medicare program. It's had strong enrollment growth for years. And that growth received a boost from the Trumpster, which has sent mails to people using Medicare to promote how much coverage they would get for less money from the private plans. Missing from those emails, however, is a mention of one big limitation. Many cover far fewer doctors than the traditional program. Now, this guy, who's this guy's name again? Austin, come on, man. You're comparing the Medicare Advantage Part C to the original Medicare. All right, what's the difference? Original Medicare, you have an unlimited out-of-pocket expenditure. You can, I mean, literally, the Medicare covers 80, you're on the hook for 20, and that could be millions of dollars. Part C, on the other hand, if the insurer is going to enroll in Part C through CMS, the Center for Medicare and Medicaid Services, it will give you a maximum out-of-pocket that you'll have. So to compare to compare the two is just silly. Original Medicare is Part A and Part B, and you have a significant expense. Medicare Advantage is Part C, which is essentially a combination of Part A and Part B with the Medicare Advantage plans thrown in there, maybe Part D, but it does give you the out-of-pocket max, or the limits, I should say, the max. By the way, I did get this article sent to me from my man J.O. over at Maximize Your Medicare, and you should sign up for his newsletter. Jay's just a machine when it comes to this stuff. The dude knows everything, what's going on, everything. I mean, I don't literally everything, but from my perspective, anything that comes to Medicare, sign up for Jay's newsletter. He sends it out basically every week. And on his Facebook page, he's got Maximize Your Medicare Facebook group. Sign up for that as well. Anyway, that might not be a problem with the doctors if you can find a plan that includes the doctors you prefer, or if you can find them in convenient locations. But that isn't often the case, as government audits of Medicare Advantage plan directories show. The Centers for Medicare and Medicaid Services, which oversees the program, found that nearly half of the entries had one of three problems: address errors, phone numbers wrong, or doctors who were no longer accepting new patients. In 2017, the DOJ reached a settlement with 2 MA plan providers over charges of misrepresentation of their networks to regulators. Can't do that. Other research reveals that Medicare Advantage provider directories are relatively poor sources of information. For example, a study published in the American Journal of Managed Care found that Google was more accurate. And I agree with that, man. I tried to do this massive blog post at the beginning of last year, about a year and a half ago, about a Medicare Advantage, maybe a year ago, Medicare Advantage plans in Georgia. I was going to say, this is what CMS is saying for the costs and whatnot. I was just trying to do a blog post to help people in Georgia. I couldn't find it. It was nuts. And that's the same time I was looking at ACA stuff for myself, too. And it's the same thing. It's like, this is insane, man. All the money the federal government has, they can't get this right, is nuts. And I don't know if that's because the providers, the insurers, aren't giving the information correctly to the CM. I don't know. But either way, you can't figure it out. It's nuts. It's painful. I said, I would rather jump off a bridge head first after slicing my wrist with 8,000 great white sharks looking up at me, just ready to devour me, than have to go through this anymore. So I never did the blog post because it's just the information was just so poor. It took forever. All right, let's see. Directory accuracy is hard, said the study's lead author, Michael Adelberg, a former senior health and human services regulator in Washington and now a leader of the healthcare strategy for some law firm in D.C. You know, he's part of the swamp. I looked him up before I did this thing, and he's been in this industry for a long time. Absolutely. I don't know if he was an Obama appointee. Usually when they're no longer at former senior health guy, he's no longer at that certain government policy. He was maybe a political appointee. I don't know, especially when they change over the administration. The old political appointees go and the new ones come in, and now they go work for law firms in D.C. That's the way it works, and it's absolutely the swamp in full force here. I don't know if this guy is, I just don't know. But anyway, I kind of chuckled at that. But he does say when a consumer joins a plan to get to a doc in the directory and then cannot, that consumer has a very legitimate beef. Exactly. Not only is it difficult for the average person to assess Medicare Advantage plan networks, but it's also hard for researchers. Nevertheless, a few things have been teased out. Working with plan directories, flawed though they may be, a Kaiser family analysis, a foundation analysis, examined the physician networks of almost 400 Medicare Advantage plans offered by 55 insurers in 20 counties. It found that networks of these plans included 46% of physicians in the county on average. In other words, if you selected a plan at random in these counties, you could expect that a bit less than half of doctors would be covered, at least according to its directory. This does not necessarily mean those who are covered are taking patients or practicing in locations convenient for you, though. Exactly. So they might be in network relative to being covered, but they might not see it because it might not be easy for you to get to, or they might not be taking new patients. And if I may, just remember, Medigap, or Medicare supplemental policies, every single doctor who accepts Medicare, original Medicare, Part A and B, is in network. From freaking, what's her name, Sarah Palin, from Wasilla, whatever, Alaska, to Bangor, Maine, to Corpus Christi, Texas. If they take Medicare, they are in network if you got a Medigap policy. On the other hand, if you're going from Wasilla, Alaska to Bangor, Maine to Corpus Christi, Texas, and you got a Medicare Advantage plan, well, you're not going to have any Medicare Advantage plans in Alaska because there are none. I have a sneaky suspicion you're not going to find many in-network doctors in Bangor or Corpus Christi. It's going to be tough because the insurers that's literally in Medicare Advantage, like an HMO, they get this network of providers and they say, okay, you're going to basically adhere to what we say and we'll provide you leads, essentially is what happens. And the doctor said, that's fine. But how many doctors in Bangor, Maine are going to be part of that Aetna HMO? And they're also going to be the same ones in the one in Corpus Christi. So now if you're in Bangor, Maine, and they are part of it, now you go down to Corpus and you have an issue of some sort, that person can be out of network? Probably. How much is it going to cost you? And that's the issue. That's why Medigap, if they take Medicare, they take your Medigap policy. In other words, we talked about that. The study found considerable variation by specialty. Psychiatrists are least likely to be included in plan networks. A typical plan covered fewer than 1/4 of them. Let's see. They talked about some other plans. Depending on what kind of care you need, the extent of which plans cover specific specialists would be important to know. But there's no single source that meaningfully compares Medicare Advantage plan networks in the aggregate, much less by specialty. But this could change. A recent draft regulation would require Medicare Advantage plans to provide their directories in an e-format that third parties could use to compare them, for example, through apps or online. Why do plan networks vary anyway? One possibility is that plans may strategically narrow or broaden their networks of certain specialties to try to attract more kind of enrollees they want, i.e. healthier, i.e. cheaper. And fewer they don't, sicker, more expensive, which is why you have to look at your plan every year. You don't have to be underwritten to go from MA to MA, from Aetna to Kaiser to whatever the other ones are. Also, United Healthcare through AARP. You don't have to go through underwriting, but you do have to go through underwriting to go from MA back to Medigap or Medicare Supplement. But you don't have to go to underwriting to go from Medicare Advantage to Medicare Advantage to Medicare Advantage. Studies have shown that sicker beneficiaries are less attracted to Medicare Advantage, as well I would think they should be. perhaps for these reasons. Another possibility suggested by an Urban Institute study is that plans narrow networks to control productivity and quality. For instance, covering only doctors who meet quality standards and tend to provide more efficient and valuable care. Valuable to the insurer, not to you necessarily. More efficient means, come on in, yep, good, poke a couple bit, you're on your own. And I hate to say it, that's the way medicine is. That's why I love the idea of DPCs, direct primary cares, where you're paying essentially as a fee, $1,000 a year, 100, whatever it is, 2,000 a year. It's an on-demand service where you're part of a what's the word I'm looking for? We're a valet essentially. You know what I'm saying? Where you're saying, okay, I'm part of this person's network, this lady's doctor's network. Anything I need is call her, and she'll be there for me. And she's only going to have 100, 200 clients. That's it. I love that DPC stuff. All right, so let's see. A study of Medicare Advantage plans offered in California in 2017 found that the quality of OBGYNs, cardiologists, and endocrinologists covered by those plans tended to be comparable to those available through traditional Medicare. But some plan enrollees, especially those in more rural areas, would need to travel far, in some cases 100 miles, to seek those covered physicians. Exactly. Going back to Alaska, there's no MA plans in Alaska because no insurer is going to want to go up there and set up a network. It's just not profitable. The Kaiser Family Foundation study found that broader network plans tended to charge higher premiums than narrow network plans. The more doctors in the network, the more people you have the opportunity to see, the more they're going to charge. Makes sense to me. Narrow network means covering less than 30% of doctors in a county. One limitation of analyzing plan directories is that even if physicians are listed as in-network, they may not really be accessible because they're no longer accepting new patients. Exactly. So another way to assess the influence of Medicare Advantage networks on people's access to care is to observe which doctors people in a specific plan actually see. Looking at it this way, which colleagues and I did on a recent study published in Health Affairs, reveals that 80% or more of MA plans provide access to at least 70% of PCPs, primary care physicians, in their markets. Well, that's pretty good. 80% or more of Medicare Advantage plans provide access to at least 70% of the primary care physicians in their market. Our study also suggests that narrow network plans are not growing over time in Medicare Advantage, which runs counter to the narrative that they're taking over healthcare. Yeah, okay. That's I'm not sure why the narrative would be that the narrow plans are taking over healthcare. Still, because there's no way for Medicare beneficiaries to compare plan networks, people could easily stumble into a narrow network plan without knowing it. As with many things in healthcare, it's hard to make an informed decision. Man, good stuff. Austin Fracht, associate professor, BU School of Public Health, adjunct professor with Harvard T.C. Chance School of Public Health. Is that the guy who paid to get his son in the tennis? Remember, there's a guy at Harvard who paid to get his son at the in the Harvard tennis. I wonder if that, and he was going to give a lot of money. I wonder if that's a guy. Anyway, T.H. Chan. Good stuff, man. He's got a blog at the Incidental Economist. So I thought it was a pretty good article. Now, look, I'm not generally a fan of the New York Times because I know the New York Times is for single payer. And Medicare Advantage is the opposite of single payer because it's a voucher program. But I do think there are problems. And to say Medicare Advantage because I support the free market is without problems would be stupid. I mean, it has inherent problems in it. And that is tough to find stuff to find out who's in network. And then you got to look at it every year. So even if you get that problem solved today, next year it's the same thing, especially when it comes to drugs. Jay talks about this all the time. When I was interviewing him about all the different Medicare plans, Medicare Advantage, he's like, the drugs change all the time. New drugs come on, old. It's nuts. Now we got this thing with EpiPens being a shortage. I mean, does your MA plan cover an EpiPen? How long does it take to get one? How much do they cost? I don't know. Did it do it last year, but they don't do it this year? So, anyway, let's see. I'm almost afraid to look at the comments in the New York Times because all these libs are going to talk about how we need a single payer. It's only a matter of time. All right. Well, that's pretty good. He talks about a new Medicare consumer this year. I can share that my months-long research and decision-making exposed the bad deal MA plans do. Yeah, but more critically, understand these plans sold on the basis of low or even no monthly fee cover nothing until you pay steep deductible. I don't know about that. The issue, again, is that at the end of the day, Medicare Advantage plans do limit your out-of-pocket expense. That's just a fact, or else they can't be part of it. But I agree with this. So do yourself a favor, choose the original Medicare option, the Medigap, right? Medicare supplement, designed the way group healthcare originally intended. Pay the modest $135. We're already paying the Part B anyway. Pay the modest $157 for a supplemental policy that covers the deductibles, out-of-pocket expenses, and even providers aptly named occasional excess, and then get a Part D prescription drug plan. I 100% agree with that, man. That's the way to go. Now, you might not have the cash flow to pay the extra $157 premium for your Medigap, plus an extra 35 to, what is it, 35 for Part D. If you don't, it's going to be tough. But I mean, just think about it. That's, $200 a month, $2,400 a year. On top of your $135 you're paying for Part B, that's another, what's that, $1,300. So that's, between those, you're looking at again, the healthcare is about $5,000 a year. That's what it's going to cost you once you hit retirement, and that doesn't include your co-pays. Now he's saying the deductibles, the supplemental policy pays, you still got co-pays and co-insurance and stuff like that. And again, but at the end of the day, you're still $4,000 to $5,000, and you're covered essentially for everything. I don't have any problem with that at all. Many clinics don't know if you're covered when you mention your plan. They direct you to the plan to find the doctors they'll reimburse. He talks about how we try free market insurance. The kind that wouldn't be limited by states. It's an argument for free market, but I love the idea of free market, but at the end of the day, this is what we're dealing with. So let's not pretend that there's a easy solution out there that's the government's going to say, no, it's all good. Trump's not going to say it's good, just on your own. Not going to happen. It doesn't make sense to encourage people to join these plans. The government pays them a fee whether or not the patient uses the services. Exactly. That's why there's always this steep competition for you during open enrollment. Was it October? Was it the last 2 weeks of September? Or was it the last 2 weeks of October through December 7th? The government spends more money on these plans than conventional Medicare. I don't know about that, man. I do not know. Medicare. You're telling me they spend more money on Medicare Advantage than on actually original Medicare? I don't believe that for 2 seconds. There's another scam by a bunch of insurance lobbyists perpetrated on the American taxpayer. What the hell is ACA? It's a scam by the healthcare. What's the AMA and the insurers on that too? How come it doesn't say that? ACA was on the insurance because they mandated you had to buy their product. Why does it? So Medicare Advantage is scammed by the insurance lobbyists. So what's ACA? Right there. I knew it. I knew it was only a matter of time. Someday the American people may wake up to the fact the only thing that makes sense is a single-payer system. I knew it. That's only 4 comments in. I knew we were going to get a single-payer comment. No networks to figure out. No seeking out doctors are willing to take Medicare or Medicaid as everyone would have the same insurance. Insurance is not care, Steve. Health insurance is not health care. I knew it. Every other industrialized country in the world has managed to figure this out, but they haven't. That's the thing. They haven't figured it out. Jeez Louise. Another single payer. All right, so down to 5 comments. 40% of New York Times comments so far has advocated for a single payer. They even give us a citing of a book to read or okay. Let's see. Let's keep going down. We are pretty much forced into using Medicare Disadvantage because our state retirement program only offered this year to people in our community. Next year, we'll look around for a totally different plan. Well, if they're on Medicare Advantage, I hope they don't have issues because they're not going to get Medigap at that point. It's not growing because people prefer it. It is growing because people prefer it. People, they survey Medicare Advantage recipients all the time, and the numbers are extraordinarily high for people's satisfaction with Medicare Advantage. Here's old Steve. The single payer plan from New York City. Imagine that. I just wonder if they think all those TV ads and mailings extolling the benefits provided by those plans are being done because those insurance companies are truly placing the interests of the people they cover first. No, they're private property. They're private entities. Absolutely. But the funny thing is, do you think Steve doesn't put Steve's insurance, his things first? That's what cracks me up, all these socialists out there. We got to put other people first. As I get mine, I want mine, but we got to put other people first. That's exactly what socialism is, man. Everybody else should put their other people first, but I'm going to get all my stuff I can. And we know that's what Steve's doing because Steve takes care of Steve. As well he should. He's human. I think the size and structure of the HMO makes a difference. Kaiser Permanente's physicians are all KP employees. In the San Francisco Bay Area, one can choose and switch between primary physicians from a fairly large base. Again, that's the issue, because once you're in a big city, you got a lot of docs available, and the Medicare Advantage plans make sense. It's when you travel or go to a rural community, you're going to have a hard time. If you're in a big city, you plan on staying there, and you're not really traveling that much, man, it's hard to argue with Medicare Advantage plans. And David is our guy, the advocate for free market solutions. Kaiser Permanente, I've heard things, because we have Kaiser Permanente in Atlanta too, and that's a pretty big HMO, and I've heard people say they got what they need, the one here in Atlanta. This guy has Humana Medicare Advantage and couldn't be more satisfied since I pay zero premium and get a $50 a month rebate. It includes A, B, and D. It includes vision and dental benefits. You're a healthy senior who takes responsibility for your health. Is a cost effect. I completely agree with that, 100%. I mean, look at that. If you're getting A, B, and D, and that's all included in the Part C, that is hard to argue. And if you're in good shape and don't see the doc much, it's hard to argue with Medicare Advantage plans. Again, if you're out of network because you travel and you have an issue, that would be the issue. You got to cover that while you're traveling out of network. Also, they pay, what was my Aunt Cynthia was telling me in California, because she lives in Whittier, they pay for, the help I fall and I can't get up thing, and they pay for something else too. I forgot what it was, but a couple detection things where your Medigaps don't pay that. The out-of-pocket limits are $13,500. Traditional Medicare is placed with absolutely far from perfect. Again, traditional Medicare is just A and B. All right, that's it. Traditional Medicare is not the solution if you're trying to cover your out-of-pocket expenses. This lady is in North Texas. My client, she has a Humana Medicare Advantage plan. Also includes A, B, and D. I pay zero monthly premium. Medicare sends my Part B premium to Humana to help cover potential costs. So she's paying her Part B to Humana, but she doesn't pay anything for Medicare Advantage. My Humana HMO includes thousands of PCPs because she's in, again, see us on top of all these people who say that Medicare Advantage plans are scams or something like that. There's tons, and we've done studies. They've done studies on this, man. Medicare Advantage plans get high ratings. And here's Linda. If she's doesn't have Susie Orman's $5 million to retire on, and she got no premium for her MA plan, and she's still gonna have Part B. But still, she had no premium, and that includes Part D, and she's in North Texas, a very a sizable community with tons of doctors. You're not going to argue with that. I'm seeing a specialist. To date, I've paid zero copays that count towards my annual $3,400 max out-of-pocket costs. All services provided by my PCPs. Premises have zero copay. I get a gym membership. That's what it was. Dental, health, and vision. I have dental, vision, and hearing coverage. And your original Medicare with Part Medicare supplements don't do that. And that's not cheap stuff, man. So that's one of the benefits of Medicare Advantage, without question. Many North Texas doctors no longer accept original Medicare because they get paid more and faster if they accept. No longer accept original Medicare because they get paid more and faster if they accept original. I guess if they accept Medicare Advantage, I don't understand what that means. Some countries have national health care. We have a gotcha, says Frank, and I guarantee be interesting to see what Frank had. And here's David again arguing the fight. So good on you, David, fight the free market fight, but let's not pretend that there are not issues with Medicare Advantage. Always visit your Shine rep at your local council on aging. They will clear up many issues. Shine reps are trained to present all the facts. When presenting an Advantage plan, the Shine rep advised to check with all medical providers that you use. The providers will advise their acceptance or rejection of Medicare plans. If you afford the max out of pocket, Advantage plans can be very good. There you go. The funny thing about single payer is as if all these same doctors are simply goes, no, we'll bend over for you, because what they're going to do with single payer, they ration. And so they say, doc, we're going to ration your fees. We're going to make sure you see a certain amount of people. If you want to stay in business, you will have to do what we say. And a lot of docs say, screw that. I'm not going to be in business anymore. I'm going to hang up my freaking heart thermometer thing, whatever it is. That thing that goes boom, 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 that they check. My stethoscope. I'm going to hang up my stethoscope. The problem is true for all insurance companies, for all doctors. Complete incompetence acceptable because it helps promote profits over people, as if our man SW in Sherman Oaks doesn't have that same for himself. All right, so let's do one more. Oh, let's see. Let's read about it. Here's an MD and a JD. All right, JD's a lawyer. All right. The author and editors completely ignore the reality that real patient outcomes are not available for Medicare Advantage plans. Cover and network adequacy are important, but more important for the actual clinical outcomes for conditions like acute MI, atrial fibrillation, stroke, pneumonia, heart failure, stratified by risk. Congress, HHS, and CMS allow for these HMOs to operate without effective oversight. As for the readers who think they got all the care they need to think about the care they need, but are never referred for and are never told about. Right now, the HHS Inspector General should investigate how many people with significant aortic stenosis and MA plans are not getting needed referrals to cardiologists and cardiac surgeons for valve replacement surgery that extend their lives. HHH and administrations of both major parties have been pushing such HMO plans for the last 30 years because the economists who run U.S. health policy like the idea of defined contributions. It makes budgeting easier and covers up rationing healthcare to some of our sickest people. I recently saw, okay, he pushes management, so I smelled fishy. Sure enough, it's upon inspection. Okay. Could someone please simplify this stuff? Geez, says a guy from New Hampshire. All right. Here's the last guy from Tallahassee. I belong to a very large Medicare Advantage plan, a state-sponsored for state retirees. We see physicians we choose, and there's no distinction between in-network, out-network. I admit I do not understand the economics of medical insurance, but I suspect that the low premiums and generous benefits of the plan are a result not only of subsidies, but they are subsidies, without question, but also costs of spreading and bargaining power derived from the high number of participants. Exactly. Isn't that what they always argue about single payer? We'll be able to negotiate better premiums. My plan isn't expensive or restrictive at all, and for that I'm very fortunate. I'll say that I fervently wish that every citizen of our country had the same access to medical care and affordability that I have. We are moving there too slowly, but I hope surely. If every citizen, your access, that's right. So Jake from New York says, here's the dirty truth. If every citizen had the same access to your plan or similar ones, your access would diminish and the cost of insurance would increase. Yep. All right. There you go, man. So that's good stuff on Medicare. And again, I would, if I were you, I'd go to my man Jay's maximize. How do I close out of this? Let me move myself. Maximize your Medicare. I'd be interested, and I'll take a poll here for my folks who are on Medicare. Again, if you have TRICARE for life, you don't need Medicare Advantage. And I don't even think you need Medigaps, if I recall correctly. Yeah, I don't think you do. But if you are on Medicare Advantage, I would like to see if you put, just give us your thoughts, good, bad, or ugly. I mean, you say whatever you want, but if you're on Medicare Advantage, tell me you're happy with it or not. And if you want to elaborate, that'd be pretty cool. Maybe I'll do a poll on that because I am interested in that for sure. So anyway, hope you find this informative. Pretty good article by New York Times. Again, every now and again, the New York Times surprises me with some pretty good food for thought. I wish they would. Who they have or was that the Washington Post? They had the lady who accused Trump or something like this. I was just like, what are you doing, man? It's nuts. Maybe that was Washington Post, but they're all the same. It's just sad because we do need real media doing real media stuff, and I just yeah. But then you go back to Walter Duranty from the Soviet Union, Stalin stooge, and the New York Times has been like this going back almost 100 years now. So all right, see you next time.